Sigmoid volvulus is a medical condition where the sigmoid colon, the last part of the large intestine before the rectum, twists around its mesentery, leading to bowel obstruction. This twist can compromise the blood supply and lead to ischemia, gangrene, and perforation if not treated promptly. Sigmoid volvulus is one of the most common types of colonic volvulus and represents a surgical emergency. Epidemiology. Age and gender. Common in older adults, particularly males. Geographic distribution. More prevalent in regions with high fiber diets, such as parts of Africa, South America, and Asia. Risk factors. Chronic constipation, laxative abuse, neuropsychiatric disorders, e.g. Parkinson's disease, institutionalization, e.g. nursing homes, previous abdominal surgery, anatomical predisposition, e.g. long sigmoid colon with a narrow mesenteric base. Pathophysiology. The sigmoid colon twists around its mesentery, leading to 1. Obstruction. The twisted colon blocks the passage of stool and gas, causing abdominal distension. 2. Ischemia. The twist can compress blood vessels, leading to reduced blood flow and potential necrosis of the bowel wall. 3. Perforation. If untreated, ischemic bowel can perforate, resulting in peritonitis and sepsis. Clinical features. Symptoms. Sudden onset of abdominal pain, typically in the lower abdomen. Progressive abdominal distension, nausea and vomiting, constipation or obstipation, complete bowel blockage. Signs. Tympanitic abdomen, drum-like sound on percussion, tenderness on palpation, visible loops of bowel, signs of peritonitis in advanced cases, e.g. rebound tenderness, guarding. Diagnosis. 1. Imaging studies. Abdominal X-ray, coffee bean sign, a large, dilated loop of sigmoid colon with an inverted U-shape. CT scan confirms the twist and identifies complications like ischemia or perforation. Whirl sign, swirling of mesenteric vessels at the site of volvulus. Barium enema, bird's beak sign, a tapered narrowing at the site of the twist. 2. Sigmoidoscopy, diagnostic and potentially therapeutic, reveals twisted and distended sigmoid colon. Management. 1. Initial resuscitation. Intravenous fluids to correct dehydration and electrolyte imbalances. Nasogastric tube for decompression. Broad-spectrum antibiotics if perforation or ischemia is suspected. 2. Definitive treatment. Non-surgical management. Flexible sigmoidoscopy or colonoscopy to untwist the sigmoid colon, successful in 70 to 90% of cases without ischemia. Decompression should be followed by elective surgery due to high recurrence rates. Surgical management, indicated in cases of bowel ischemia, perforation, or failed endoscopic decompression. Procedures. Sigmoid resection with primary anastomosis in stable patients without peritonitis. Hartmann's procedure for unstable patients where resection is followed by a colostomy. Elective sigmoidectomy is recommended after successful non-surgical decompression to prevent recurrence. Complications. Bowel ischemia and gangrene. Perforation leading to peritonitis. Sepsis and shock. Recurrence occurs in 50 to 90% of cases managed non-surgically without definitive surgery. Prognosis. Good outcome. Early diagnosis and timely intervention. Poor outcome. Delayed treatment, ischemia, or perforation. Mortality. Higher in elderly patients and those with comorbidities or complications. Prevention. Treat chronic constipation and other predisposing factors. Timely surgical intervention for recurrent cases or high-risk patients. Sigmoid volvulus requires a high index of suspicion and prompt management to prevent life-threatening complications.